Hey guys, so welcome. We're going to come back again to revisit the idea of heart disease, which is totally on point because today is actually Go Red for Women Day. And so I'm actually recording this on a day that is dedicated to women's cardiovascular health. And we're going to talk about cardiovascular health, and we're going to use a woman in order to do that. So we're going to go back to dealing with our patient Linda. Now, we looked at her previously, and we were looking at her cholesterol levels that were coming through and that she was having a buildup of atherosclerotic plaque. Now we're going to continue on with Linda in our services to her, and she's going to come back and revisit the doctor, and we're going to deal with what happens when she's coming back in and maybe showing some different signs and symptoms than the last time that she did. So let me just change my camera a little bit. And we're going to start off with Linda and come back with an update. So an update on Linda. So now she's coming back to us, and she's a 42-year-old woman who is 5'3" and 185 or 184 pounds. And that makes her with a BMI of 32.6. Now, when we look at that and we're looking at like, what does that mean? Really, we're putting her into the category of being severely obese. So she has obesity with this type of a BMI. Now, she owns her own cosmetics company. She ends up traveling a lot and works over 60 hours per week and ends up eating a lot out at restaurants or ordering room service because she is just always on the go and always traveling. At home, she mostly is eating some TV snack tray dinners because there's just no time for her to cook. She's a busy woman entrepreneur and is struggling to try and make her business grow a little bit more. So when we look at her family history, we show that her father actually underwent coronary artery bypass surgery at the age of 43. So we notice that she is 42 years old, right? And that's probably what's bringing her back into the doctors, because her dad ended up having a coronary artery bypass surgery at the age of 43, and she's 42, and she's starting to exhibit more signs and symptoms. She really has no time or very little time for any kind of exercise. She currently is taking her Lipitor, which we had prescribed her. Remember, we were physicians that we prescribed her for her atherosclerotic plaque buildup and her cholesterol levels, but she actually doesn't remember what it's for at this time. And now, the question is, what would they like to know? We're going to collect our baseline vitals, right? Baseline vitals, respiratory rate is 16 breaths per minute. Heart rate is around 82 beats per minute, and a blood pressure around 158 over 92 millimeters of mercury. So that's changed significantly since the last time we came in. Last time, her blood pressure, I don't remember exactly off the top of my head, but it was like 120 something, maybe 128. So now we've kind of excelled into a slightly larger area of hypertension as we go on. When we look at our blood test, her blood tests, the total cholesterol is around 252 milligrams per deciliter. Don't mind my dogs. Her LDLs are around 173 milligrams per deciliter, and her HDLs are 38. So this is actually a little bit better than what we saw previously when we took her in the first time and prescribed her the Lipitor, but you'll notice that it's still kind of high. And her triglycerides are running around 205 milligrams per deciliter. When we look at her blood glucose levels under fasting conditions, she's around 110 milligrams per deciliter. So we're still looking at that pre-diabetes type of range. So when we're looking at her problems, she seems to still be having issues with her cholesterol levels, still having a little bit of issues with pre-diabetes, and we're looking at hypertension at this point, having that high of a blood pressure taken over multiple different visits, we'll say, so it's not just a one-time reading. So let's talk about hypertension for a little bit. So what do we know? So I want you to take a moment and pause the video and just brainstorm to yourself, okay, what are our normal levels of blood pressure and what kind of classifications do we have based on if our blood pressure goes up, how does that fall in? What is the actual qualifications to be considered pre-hypertensive, hypertensive, and the different stages of hypertension that we have? And then ask yourself, what could be causing this in Linda? So what's going on with the history that we already know? What potentially could be some markers of what's happening? And then what do you already know about how to treat hypertension? So we're going to stop the video and I want you to brainstorm those things on a separate piece of paper for just a moment before we continue on. All right, so when we take a look at the prevalence of hypertension, it's actually very interesting to look at this segregated by sex and then look at it within age groups. So what you'll notice is when we are taking a look at, I don't have my cursor here, but what you can see is when the males are in the black and the females are in the dark gray. And what you see is that in those early years, the 20 to 34 and 35 to 44, what happens is that men are at a higher risk for hypertension than females. But then all of a sudden something changes right around this time period right here, and you'll actually see it switch where women become more prone, or there's a higher prevalence of hypertension in women once we hit around this age. So the question is, why this age? What could that possibly be? Now, some of you might be thinking, yes, that is when we start to go through menopause as women. And that is very true, that we are cardioprotected by our estrogen levels when we are at younger ages from cardiovascular disease because of that estrogen level that we have within our system. However, as we start to decrease in our estrogen levels is what's happening when we start to go through menopause, all of a sudden that switches and we actually become at higher risk for hypertension in comparison to males. So we often think about hypertension or cardiovascular disease as a man's disease. And in fact, it is not just a man's disease. It actually is a feminine disease as well, and especially as we get into the older ages. That is exactly what the Go Red for Women campaign is all about, to actually teach people that no, breast cancer is not actually the leading cause of death in women. It is cardiovascular disease. So keeping that in mind, we're going to proceed forward though, but I just wanted to give you that information that really when we look at it, it's a female disease. It's not just a man's disease. So we do have different classifications of hypertension, and we kind of have them listed right here. So, so normal physiology, normal blood pressure is looking at when we are at 120, less than 120 milligrams of mercury for our systolic blood pressure, or under 80 for your diastolic blood pressure. So that's what's considered normal, is to actually be under those amounts. So we used to think that 120/80 was what like our normal blood pressure is, but those are actually the high side of normal. And as soon as we start getting into where the systolic blood pressure is over 120, we actually are now getting into the hypertension realm, right? So it's when our systolic blood pressure is above 120 but less than 139, or our diastolic blood pressure is between 80 and 89. So if either one of those are true, that is considered pre-hypertension. And of course, this isn't just a one-time reading. It's taken multiple times over the long haul and using in different situations as well. So you're just making sure that it's not just error as far as the reading goes, or it's not just reacting to the stress at any particular moment. As we increase in systolic blood pressure and or diastolic blood pressure, we're going to move into the classifications of hypertension, starting out with stage 1 hypertension, which is the 140 to 159 millimeters of mercury for the systolic blood pressure. And then between 90 and 99 And it could be either one of these are elevated, the systolic blood pressure or the diastolic blood pressure between 90 to 99 millimeters of mercury. Then we move into stage 2 hypertension, which is anything that is going to have a systolic blood pressure above 160 millimeters of mercury and also a diastolic blood pressure of over 100 millimeters of mercury. And in fact, we're actually starting to move into even higher realms with a hypertension classification of a stage 3, which is even higher than that. So looking at blood pressure, this is where we're wanting to be. We want the blood pressure of like 110 over 70. That's actually what our normal is now, is 110 over 70. Anything that we're getting above 120 over 80 is going to be classified as either prehypertension or hypertension. So what are our causes of hypertension? Now, there's many different causes that we have. We're going to take a look at just exploring 3 of them and then talk about the one that is the most likely suspect when it comes to Linda. So one of them is literally just within the renal system itself. So remember, last time we talked, we went over the renin, angiotensin, aldosterone system and took a look at how that plays a role into long-term blood pressure regulation. Well, oftentimes we can end up having kidney disease of some sort or another, and it actually is impacting that renal system in the control of our blood pressure. And so often that is a cause. It's one of the highest causes that we have of hypertension. Another example would be sympathetic nervous activity overdrive. So you can have different types of conditions that actually make it so that your sympathetic nervous activity is actually already heightened and more sensitive to other stimulus that are coming in. An example of that could even be like polycystic ovary syndrome. That tends to have a high level of sympathetic overdrive, in which then that tends to lead to more cardiovascular disease in people who have PCOS. Right? So that's an example of them. There's many other conditions that do that. And literally just having stress all of the time can lead to hypertension because you are always in a heightened state of having this sympathetic nervous activity always active. Now, when we talk about Linda, remember we started from the premise of that we're dealing with atherosclerosis and the high cholesterol levels. And that was coming about all because of this endothelial dysfunction, right? The lining of the blood vessel was disrupted and wasn't able to respond to all of the chemicals that dilate it and constrict it as easily. And this is probably where Linda's is coming from. So let's just take an example. And I'm presenting this as it's a cause and effect, that atherosclerosis leads to hypertension. And in fact, the opposite can also be true, right? We'll talk about that in a minute. But remember, we had our picture of our atherosclerosis that was starting to build up. So we had at the top of this picture, we had normal healthy arteries. And then as you move further down in the picture, it's showing you that development of plaques that are starting to form. Now, remember, what it ends up doing is it actually pushes out on the blood vessel wall first, right? That buildup of plaque within the blood vessel lumen, or excuse me, in the intima, will first push out towards the outside of the lumen. Then only once it's kind of reached its growing point, pushing out on the artery, it will start to actually come in and impede blood flow within the lumen itself. So within the actual blood vessel itself, blood is having a harder time pumping through because of the resistance that's there. So just imagine right now, okay, we had this equation we already took a look at, that flow equals the change in pressure over our resistance, right? That was just looking at physics itself. We put that into the equation that was applicable for the body, which was our cardiac output, which is represented here by Q, which is flow. So our cardiac output equals our mean arterial pressure divided by our total peripheral resistance, right? And that total peripheral resistance is often kind of determined by what that diastolic blood pressure is, but it's looking at that a resistance of the blood trying to pump through those arteries. So it's a combination of your diastolic blood pressure as well as any endothelial damage that you have. Now, if we just take that equation and we rearrange it, right? All we're doing is rearranging it to solve for total peripheral resistance. it would mean that total peripheral resistance equals mean arterial pressure divided by our cardiac output. So all I did was I took the equation that we were looking at to solve for flow, I rearranged it to solve for our total peripheral resistance, because I'm going to use this as an example. This is what it looks like in theory. We don't technically usually measure total peripheral resistance. It takes really invasive means to be able to do that, but we can calculate it based off of what the mean arterial pressure and what the cardiac output is, which is actually easier to measure, or at least easier to estimate. So an example of a normal healthy person, or maybe even bordering on prehypertension, would have a mean arterial pressure of around 90 millimeters of mercury. Okay, so that's taking into account 2/3 of your diastolic blood pressure and 1/3 of your systolic blood pressure to give you an average blood pressure, because we spend more time in diastole than we do in systole. So when we measure blood pressure as one number, we kind of account for that and make it so that it's 2/3 of our diastolic pressure plus, and then the difference between, let's say the difference is our pulse pressure. So the difference between our systolic blood pressure and our diastolic blood pressure, and then accounting for that, we are more often in diastole. So average mean arterial pressure, bottom line, is usually like around 90. That's what most people will be under in the normal, circumstances. And in resting conditions, typically cardiac output will be around 5 liters per minute. Okay. So if I use that calculation, what it would show for our total peripheral resistance would be about 18 millimeters of mercury per minute per liter. Okay. You don't need to know these numbers necessarily, but I want you to understand this concept. So let's say we are starting to build up with higher resistance in our arterioles because of this endothelial dysfunction and the atherosclerosis that is starting to happen, in combination, probably with some high blood pressure as well, but even just that resistance. If we were to take that resistance and say double it, right? So all of a sudden it just completely changed the resistance, and all of a sudden it's a lot harder for us to be able to pump blood through the body. Well, if I double one side of any equation, what I'm going to have to do is also double the other side in order for them to equal each other, right? I can't just create numbers from nowhere. So I've actually got to balance the equation, right? So if I'm taking my total peripheral resistance and saying that it's doubled, I'm going to have to also double the other side of the equation, right? So all I did was took my 18, which was the millimeters of mercury per minute per liter, and I doubled it to get the 36. Then I'm going to take my 90 millimeters of mercury from my mean arterial pressure, which is divided by our 5 liters per minute of our cardiac output. I'm going to have to take that and also double it. Now, I could either choose to double my pressure, or I could half my flow in order to actually balance this equation. So what I'm looking at here is I could keep flow the same, right? I still need to have blood flow going to my brain. I still have to have the same amount of blood feeding all of my cells within my body. So if I wanted to maintain flow in my body and my total peripheral resistance had just doubled, I am going to have to double my pressure in order to overcome that resistance, right? So all of a sudden, instead of having 90 millimeters of mercury for my mean arterial pressure, I would have to have it doubled if I want to maintain my flow at 5 liters per minute for my cardiac output, right? Or the other option is say like, oh, I don't really care about my flow. I want to keep my blood pressure the same. I would then have to half my flow, right? So that's just balancing the equation that we have right there. Now, the reality is what happens is we kind of do a combination of both. We'll probably reduce flow to the heart, to the splanchnic region, to working muscle, to the brain itself. So we'll reduce flow a little bit for what can be afforded, and then also up the pressure in order to overcome this increase in the total peripheral resistance. So this is kind of just showing you that relationship between these different variables of when we have this resistance that's in the body and what has to happen with our either mean arterial pressure or with our cardiac flow in order to kind of balance out all of the equations right there. So what ends up happening is here, we've got a little bit of arterial buildup right here, not much vasoconstriction right happening, so we can have a normal blood pressure. But as we get more advanced in this blood vessel, as we're moving across the screen, that we move into hypertension because there's more of a buildup and there's more systolic pressure that's needing to be used to overcome that resistance that's further down wherever that atherosclerosis is building up, to the point where maybe we don't really have a whole lot of blood flow. There's a lot of resistance and it's adding to our hypertension at that point. Now, as I said, I'm painting you this picture of this atherosclerosis leading to hypertension, and that's not always the case. In fact, some people can start off with having hypertension because of other realms like renal system failures or, issues with the renal system, or with just that chronic presence of the sympathetic overdrive. And it could actually cause a lot of shearing on the blood vessel themselves, which would open up places for those LDLs to be able to cross the barrier into the intima and then oxidize, like we talked about last time, and lead to those atherosclerotic plaque buildups. So it can go in both directions. In this one with Linda, I'm just showing the picture of how it might progress in one particular way. So now we're talking about, okay, if we've got this resistance we have to overcome, we're going to have to increase our pressure and probably also reduce our cardiac output a little bit, but definitely increase our pressure in order to try and combat this resistance that is stopping blood from being pumped around to the rest of the body. Our, brain still needs oxygen to be able to get to it, so we've got to pump stuff around. So we're going to increase that blood pressure as we do it. Now, one way we've already talked about within this class, on the last time that we talked about heart disease, is to actually take a look at our sympathetic system, right? So it would be the same thing as if we went from resting to exercise, or in the example here, it's going our laying down. Remember, we talked about laying down and then standing up and how that will actually reset the baroreflex, right? So the same thing is happening, right? If all of a sudden we've got resistance and there isn't a whole lot of flow that's going through to get to the brain and other areas within the body, we're going to sense that, and it's going to send these messages from the aortic arch and from the carotid bodies up to the medulla oblongata, and it's going to say, wow, we don't have enough stretch. We are looking at what we consider a pressure error, right? So we've got this pressure error, right? And so we're going to decrease the firing at the carotid arteries and the aortic arch, which in turn is going to go up to the cardiovascular control center, and it's going to activate it in order to increase our sympathetic output and reduce our parasympathetic output. So this is stuff we already talked about on the last time. If you need a refresher, go back to that video to be able to do it. But basically what we're going to end up doing is to lead to more vasoconstriction because of the result of the sympathetic drive that we have, the activity that's having there, which will help to change our blood pressure in order to try and get that blood pressure back to normal again if we're sensing it as being too low, or in this case, we're just sensing it as too low for us to actually maintain cardiac output, right? We also are going to work on the parasympathetic activity in order to decrease the firing to the SA node so that we can actually increase that heart rate. The sympathetic system also is increasing the heart rate, and we're also getting an increase in that force of contraction in those beta cells, in the contractile cells of the heart, in order to increase our cardiac output so that hopefully we can make up for any of the resistance that was happening in Linda. All right, so that kind of gives us an example of how we're going to increase that blood pressure. So what are we acting on, right? We're going to go back to these receptors just to kind of hone it in and make sure you guys understand. So it's going to attach on to this. The sympathetic nervous system is going to release neurotransmitters and hormones. Neurotransmitters primarily are going to come in the form of our norepinephrine, and then hormone released about 80% of that in epinephrine. And those are both going to go and bind onto a couple of different receptors, such as our alpha receptors that we have located in our arterial smooth muscle, which will help us to contract that a little bit more. Also, vasoconstriction is going to happen because of that norepinephrine that is coming from the sympathetic nerves, right? And then also from the epinephrine that is coming from the adrenal gland as the hormone. So it attaches onto our alpha receptors in order to vasoconstrict. Then on the beta receptors, beta 1 receptors that we have, these are the ones that are located on the autorhythmic cells and on the contractile cells. So it can act on our SA node to actually increase the firing of our SA node so that we can actually increase that rate. And then also there are beta 1 receptors on our contractile cells of our ventricles, and that is what increases the contractility. Most of this is coming from actually epinephrine as a hormone. There are some effects of norepinephrine from the sympathetic nerves that are firing, but traditionally what ends up happening is that we're looking at norepinephrine typically acting on our alpha receptors more, and then epinephrine tends to act on the beta receptors a little bit more. Now, when we're looking at our alpha receptors and doing our vasoconstriction, that's most highly related to increasing our diastolic blood pressure because it's increasing the resistance even a little bit more. With our beta receptors now also being activated, what's going to end up happening is when we are increasing our heart rate and increasing the contractility, that tends to play a heavier load on our systolic blood pressure. So both, we're working in two different ways to be able to increase the pressure in order to compensate for any time we have this drop in pressure or a perceived drop in pressure that we have. Okay, so hypertension. What are some lifestyle modifications that people can do? It's going to look very similar to what we looked at previously when we were looking at the cholesterol levels, right? So we've got a weight reduction that can happen, and that will actually make it easier for them to be able to reduce their blood pressure. And actually, it's a pretty good realm. So just losing weight in general can drop your systolic blood pressure about anywhere between 5 and 20 millimeters of mercury per 10 kilograms that are lost. So when somebody is very obese in nature, losing weight, whatever they're doing to be able to lose weight, it comes through a lot of these other things that we're going to look for as far as modifiable risk factors as well. But you can actually drop your blood pressure a lot by losing weight. However, eating certain specific types of diets that are geared more towards reducing hypertension can be very helpful. So like the DASH diet is an example of one that some doctors will put clients on. It's the Dietary Approaches to Stop Hypertension eating plan. And really, it's a diet that's really rich in fruits, vegetables, and low-fat dairy products with reduced content of saturated fats. And that does a pretty good job at being able to reduce systolic blood pressure here as well. There's also just like reducing salt intake. Salt impacts blood pressure quite a lot. And so you can see a drop in blood pressure just by reducing your salt intake. Physical activity is very good for you. It does help with hypertension. And actually what we're finding, it does drop it a little bit, which is good. We're actually finding this is most effective in the pre-hypertension phase. So actually there was a study that was done at the University of Oregon maybe a decade or two ago, and it actually took individuals who were diagnosed with pre-hypertension, who were sedentary in their lifestyles, put them on a walking regimen in which they walked for 5 days a week, I believe for a half an hour each day at a moderate pace, and within 2 weeks would drop their blood pressure from that pre-hypertension stage down into normal ranges again. When you're in the hypertension ranges, it doesn't seem to have as much of an impact because I think there's just a lot other things that are going on, and simple adding of walking isn't going to necessarily treat it. It is helpful to it, but it's not going to treat it entirely. So I thought that was really interesting. When you already have normal blood pressure, it doesn't tend to drop your blood pressure any lower, except for about, for a few hours after you've walked, which is just a post-exercise hypotension that happens to everybody, which is actually one of the benefits of exercising, is because you reduce your blood pressure for at least a couple of hours, if not a full 24 hours, depending on the intensity of your exercise. Your blood pressure will drop for that period of time before it starts to raise up again. So if you're just exercising every day, which is what's recommended, you're constantly keeping that hypertension or keeping that blood pressure lower over time. And then also just taking a look at alcohol consumption. Always only drinking in moderation can help you to reduce your blood pressure a little bit, but it's a smaller amount. Drinking doesn't play as much of a role in our hypertension. All right, so now we're going to take a look at medications. We've already talked about a few of these medications and what happens, what receptors are active during different parts of when we're increasing blood pressure and how the heart is working. So now what we can do is work our way backwards and take a look at the pharmacology that is behind treating hypertension. So there's a variety of different medications that are used to be able to treat hypertension, such as beta blockers, calcium channel blockers, ACE inhibitors, aldosterone receptor blockers, and also diuretics. So what I want you to do, we're going to stop the video for a minute, and I want you to brainstorm, not just like, I take beta blockers, it's going to block my beta receptors, and that's going to decrease the work of my heart. I want you to tell me, get down to the physiology of where are these beta receptors? Where are these calcium channels, right, that are going to be blocked? What is it that's happening with ACE inhibitors, and why is that ultimately leading to a decrease in hypertension when they go on these medications? So take a time to actually delve in and try to problem solve this before continuing on with the rest of the video. Okay, so let's take a look at some of these and go over what is it that's being impacted. So our beta blockers, I'm going to move my picture around just a little bit more. So our beta blockers, if the mechanism of action is that it's blocking the sympathetic stimulation because there's a competitive inhibition at those sites. And it can either, depending on which beta blocker it is, it could be selective or non-selective. So some of them are selective, some of them are non-selective as far as which beta receptors are being blocked. So these are blocking our beta 1 receptors, the ones that we're looking at for hypertension, when they're selective, in order to actually block that increase in heart rate that happens because of the beta receptors are activated when it increases our SA node firing. And it's also going to block our contractility from increasing. So those are the beta receptors, the beta 1 receptors on the heart that are being blocked. So ultimately, you get a reduction in the resting and exercising heart rate. When we do that, it's also going to, because heart rate is a component of stroke volume, you're also going to see it decrease when it decreases in the stroke volume, it's because of the contractility. And because we are impacting both heart rate and contractility, we're going to see a change in that cardiac output as well. So we get a resting reduction. We also get a resting and exercising blood pressure reduction that's coming because of that. And then we also can get a reduction in the angina that is produced, which can potentially be reducing our myocardial oxygen demand. So it actually helps us to not have angina as much because we're reducing that demand because we're not beating the heart so fast and not with so much force as it goes through. So When is beta blockers contraindicated? Well, if the patients are already starting with a sinus bradycardia, so if their resting heart rate is below 60 beats per minute, most likely they're not going to have a prescription for beta blockers, because we wouldn't want to drop that even lower than what it already is. And then any kind of a patient that tends to have almost all of the different heart blocks will also not be using a beta blocker, because we found that that actually prolongs the heart block even more and can potentially lead them into an arrhythmia that's even worse. So precautions with our administration of beta blockers could be that it actually exacerbates breathing problems, because if it is not selective on only beta 1 receptors and it actually is acting on the beta 2 receptors that we find in the bronchioles as well, so it can cause issues like that. And then there's examples of what some of the different types of our beta blockers that exist out there that our patients would be using. All right, so our calcium channel blockers. So it's blocking calcium channels, but where are these calcium channels that are being blocked? Well, it's a couple of different places that we can see it. So it actually is going to change the flux of the calcium ions to the vascular smooth muscle. So looking at the actual contraction of the blood vessels themselves, right? So it's going to reduce that vasoconstriction. And then also the cardiac muscle, because we have calcium is highly regulating the slow channels that open up in order to produce the contraction of the heart itself. And then for that, you're going to go back to Corey's lectures on how the different cells within the heart actually work to be able to contract at the heart, or back to A&P. So the results on that is that you're going to end up reducing that total peripheral resistance, because vasoconstriction is a portion of that. So if we can vasodilate, or rather just vasorelax those blood vessels, we can decrease that total peripheral resistance, which is essentially decreasing our afterload, right? The resistance that our heart has to overcome in order to actually beat blood around to the rest of the body, right? So that in itself is going to reduce the demand of the workload on the heart, and reduce how much oxygen is needed by the heart, because it's not working as hard to be able to do that, right? So it is an inotropic type of a medication in that it's working on the strength of the contraction, right? As opposed to a chronotropic, which is working on the heart rate, which we saw within a portion of the beta blockers, but also beta blockers are both chronotropic and inotropic, because it also affects the contractility as well. Precautions is that since calcium channel blockers are primarily metabolized by the liver, that they could be contraindicated in patients who are having issues with the liver of some sort. So they might not be prescribed to people who are having liver disease. And then examples of the different calcium channel blockers that we might encounter. All right, so taking a look, just going back, I thought I would pop this in here for a moment, and the role of calcium in muscle contraction, which includes our smooth muscle contraction. A lot of it comes through calcium, right? So this calcium here can come through in order to get into the cell itself. You also have the sarcoplasmic reticulum, which is a calcium-induced calcium release, right? So here's a calcium channel that we have right here, and a calcium channel that we have right here. Ultimately, this leads to the process in which calcium will end up binding to our actin, and it binds to be able to remove the tropomyosin away, so it exposes the troponin. Oh my gosh, we're going all the way back to last term in pathophysiology talking about muscle contraction, right? We have the tropomyosin that is curled around the actin fibers, right? And it's blocking the troponin binding sites. So calcium is what goes on, attaches on there to be able to remove it, so that then we can actually have the myosin bind to the actin, right, and activate that. So that's all calcium is binding to that troponin to be able to remove that tropomyosin, right? So when we block this calcium, it means that we are blocking the ability to be able to contract those muscles a little bit. It's not going to block all of them within the body, but it's going to block some of them, right? Which then will end up leading to a less contraction, right? Which then is going to, in turn, reduce constriction that we have. So it's a vasorelaxation, which means the heart doesn't have to work quite as hard to be able to pump blood through, because the blood pressure will be reduced a little bit more. Angiotensin converting enzyme, those are our ACE inhibitors. So we talked about the renin, angiotensin 2 aldosterone systems that we have, right? So this inhibits the conversion of our angiotensin 1 to angiotensin 2. And remember, angiotensin 2 is a huge vasoconstrictor, right? And so whenever we can block this production, a sense of converting the angiotensin 1 into angiotensin 2, we're going to have less vasoconstriction within the body, right? And it also, angiotensin 2, beyond just being a vasoconstrictor, also stimulates the release of aldosterone, which also leads to fluid retention. So we can actually decrease that as well. So it's going to end up decreasing our vascular resistance, right? Because we are blocking that conversion into angiotensin 2. It also blocks the sodium reabsorption because of that aldosterone inhibition, right? Which then results in it changes, right? It results in the fluid retention via aldosterone and the antidiuretic hormone that we have, right? So, but because ACE inhibitors promote diuresis, the concentrations of electrolytes like potassiums can increase way beyond normal levels. So it's a precaution that people have to take in making sure they're getting their potassium levels checked. Otherwise, they can end up having like hyperkalemia, right? And dealing with those issues. And here's examples of what we have with our ACE inhibitors, right? Latensin and acriprol. Another medication that we have is aldosterone receptor blockers. Those bind to mineralocorticoid receptors that are primarily in the kidney, and it prevents binding of aldosterone. So when we're doing that, in effect, what's happening is we're preventing that sodium reabsorption and that volume overload, because we are preventing aldosterone from being able to bind. Very similar to what we just said with what we just saw with the ACE inhibitors. Diuretics act by diminishing sodium resorption at the different sites within the nephrons. So it increases urinary sodium and water losses, because water's always going to follow that sodium, right? And so you're going to see more water being peed out. Less fluid retention is going to mean that there's less fluid in the system, which is going to decrease the pressure as well, because of how intricately combined our blood pressure and cardiac output is. And cardiac output is all about stroke volume, which all comes from the amount of blood that is actually present within the body. There's also some aquaretics that inhibit water absorption by blocking vasopressin receptors along the connecting tubule and collecting ducts. So that's another kind of subset of diuretics that we have, and it just simulates the diuresis, right? Those are examples would be like the thiazides and furosemide. There's also cardiac glycosides. I'm not going to get into them as much, but they're ionotropic agents that will actually end up activating or changing our stroke volume and decreasing that stroke volume. But there's a huge toxicity. They are one pill killers, like digoxin is a one pill killer. So we have to be very cautious with those, and they should only be really used in circumstances where it's absolutely needed, such as with symptomatic heart failure, because we have to kind of pull out the big guns with that, because they're not going to be able to pump enough blood around when their ejection fraction is so tiny. Okay, I'm going to cruise through this next section to be able to get to talk about the last part that I want to talk to you about today. So, update on Linda. We're going to go 58-year-old now. So we've kind of upped our age a little bit more. We've upped her weight that goes along with that. So her BMI is even a little bit higher. She's been trying to figure out what to do with her company. She has a niece that she could leave it to, But her niece doesn't seem to show a lot of responsibility, and Linda doesn't want the company to just disappear because her niece isn't actually building the business anymore. So there's a lot of stress that's related around her job as she's trying to figure out what to do to retire. She's been feeling a lot of pressure and pain in her chest, especially during times of great stress, right? So that's a red flag for us to think about. She's changed from eating out to eating at home now, but she still continues to eat food that is really fast to prepare, mainly things like canned vegetables, boxed pasta, TV dinner still a little bit, those kinds of things. She joined a group, a workout group of like-aged women to try and get more exercise, but she's finding she's becoming very winded when exercising and sometimes feels the same pain as when she is stressed. Okay, she's currently still taking the Lipitor, and we had prescribed her some diuretics and some ACE inhibitors, right? So we're looking at trying to reduce that blood pressure. We're reducing the cholesterol, but lo and behold, she's still not doing well. So taking a look at her vital signs that we have, right? Blood pressure is now 148/86, which is better. It is being treated with her blood pressure medication. We would like to see that even drop into more normal realms, but at least it's better than what it was. And her cholesterol is kind of just hanging steady right around the same what we saw in the last doctor's visit, as well as her blood glucose level, fasting blood glucose level, which is elevated a little bit, but we're still in the pre-diabetic range. Important to note, we do a test on her cardiac enzymes to be able to test for if she was having a heart attack, and they do come back normal. So she's not currently undergoing a heart attack. It's more like we're dealing with our chest pain, which is where we're going to go into next. I know you guys have already talked about this with Chris, so I'm not going to deal with it as much. I want to get to a certain point, but we're taking a look at our signs and symptoms of ischemia. And because it is go red for women, what I want to make sure that I'm telling you guys today is that this clutching chest pressure, the pain in the jaw or going into the neck or the back or down the arms, and that difficulty breathing, these are all classic signs and symptoms of the typical male heart attack. We don't understand why. If I had enough gumption, I would actually start studying it, but nobody has been able to determine why. But females don't tend to display these same signs and symptoms as predictably as males do. Females often, and when they're going through a heart attack, will complain of things like lower back pain and indigestion and just feeling like I just can't get out of bed, right? So we've got lower back pain and indigestion and just like feeling crappy overall, a little bit nauseated. No woman is going to go and say, oh, maybe I'm having a heart attack, right? This is also the case with a lot of the elderly individuals and also diabetics. They have more diffuse symptoms of heart attacks. So if you're hearing a woman who's like, I'm just exhausted and fatigued and I can't do anything and I've got this back pain, it's worthy of going and getting things checked because she could be in the middle of a heart attack and just not even realize it. So what ends up happening is a lot of women will end up going to a doctor later down the road, and they'll end up seeing those hall marker symbols in their EKGs showing that they've had a heart attack in the past, such as the widened Q wave. If you can see daylight through the Q wave, you're looking at somebody who has had a heart attack in the past, right? And you're seeing these markers and the doctors are like, oh, you've had a heart attack before. And the women are like, no, I've never had a heart attack. They just didn't realize they had a heart attack, right? It's more the GI distress and the back pain and such that they're exhibiting. So what is going on when we have angina? We're getting a reduction in the coronary blood flow at some point. And it could be being brought on because of atherosclerotic plaque, right? That's just building up and narrowing the diameter of that lumen of the blood vessel. It could be because there is spasming that is happening within the coronary blood vessels. So it's just like a transient contraction that can happen. It's usually either because of some type of an endothelial contraction that's happening, dysfunction that's happening that leads to the contraction, or it could be literally just all of a sudden like a release or a stimulation of the sympathetic nervous system that could potentially happen. And it can be a combination of them both, where you have a vasospasm that's occurring on top of having atherosclerotic plaque, right? But what we can do and then also, of course, we can include in there if there's actually an occlusion because that lesion of the atherosclerotic plaque opened up and actually released that thrombus, right? But here is an example of an arteriogram that was done on a patient. And here what's happening is on the screen on the left-hand side, you can see where the arrow is pointing is that there's nothing there. You've got clean blood flow going through without any problems whatsoever. But whenever this person would become stressed or would increase in their level of activity. So they actually put this person on a bike, I believe, in order to simulate that exercise or to actually create that exercise. And what would happen is over here on the picture on the right, you would see there's a blockage of that coronary artery because of this vasospasm that was happening, right? And so it would only come on when they were exerting themselves more or under stressed situations. So this would be a very typical example of what we could see with angina. Right, so angina pectoris, in which we have a temporary blockage of blood flow that's happening, right, instead of a permanent blood flow, and it can be brought on by any of these things that are listed here, with the exception of the thrombus, because that's more dealing with cardiac tissue death, not just a brief spasm. So our arteries. Our bodies are amazing in the fact that when there tends to be lesions or buildup in some of our arteries, it will create new passageways to get around those buildups, right? So here's an example on the left-hand side of the screen in the character drawing. You can see blood flow is coming through the coronary artery quite nicely and flowing. But what were to happen if all of a sudden we have a lesion start to occur and blood flow can't actually get through that main coronary artery anymore? Well, we already have systems set up that we can actually bypass it. It's called the natural bypass, in which you can actually reroute that blood flow through other coronary arterioles that are smaller to be able to get around wherever that lesion is. And also, this blockage from this lesion can actually stimulate angiogenesis. So when I say angiogenesis, angio is our blood vessels and genesis is the creation of new ones. And it actually creates new blood vessels to act as this natural bypass. So what you can see over in this angiogram that you're looking at, this picture, or the arteriogram, in the arteries that you can see that look a little bit more solid white, those are the natural ones that we're born with that are our primary coronary arteries. Then all of a sudden you'll start to see these ones that are a little bit lower down that are all like curly. Do you see that? That they're not straight and smooth. They have more of like this curly nature to them. Those are ones that were created through angiogenesis because there were lesions that were occurring and blockages that were happening, or a slowing down of blood flow that was happening in certain regions of the original coronary artery. So these are ones that have been grown grew alongside of it in order to bypass it. So that's a natural bypass that we have. So the difference between our angina and our myocardial infarction, we know, is temporary blockage versus actual tissue death. When you get the actual tissue death, that's our acute myocardial infarction. So that's the difference between the two. Some statistics that are kind of interesting to know. In the US, a heart attack happens every 29 seconds, and death from a heart attack is every minute, right? Those are pretty big statistics. It is the leading cause of death in the United States as well as any industrialized nation. I am making sure to notify you this because we are on Go Red for Women Day, right? For about half the men and about 2/3 of the women who have heart attacks, their first symptoms that they feel are immediately preceding the fatal heart attack. Meaning, so the ones who die of a heart attack, so those, let me just start that over again. So every 29 seconds, there's a heart attack, and a death from a heart attack every minute. Of those who are dying from heart attacks, their first symptoms that come on are right before they actually died from the heart attack. So the question is, why is that happening? Why are people not getting better notice that they have heart disease, right? They have no concept that they've had heart disease whatsoever. And then all of a sudden they get these tiny little symptoms that say, oh, maybe I'm having a heart attack. And then all of a sudden they're dead. Well, a couple of reasons why. So sedentary lifestyle, first of all, is going to limit the exertion. And a lot of the symptoms that are coming on because of atherosclerosis and that plaque buildup isn't seen under resting conditions. It's only when we start to exert the system a little bit more and have higher intensity exertion levels, right? So the sedentary lifestyle just really it inhibits people from actually being, seeing any signs and symptoms because they're not stressing themselves enough to have signs and symptoms until it's too late. Also, taking a look at that rupture-prone plaque versus the stable plaque. So remember, the rupture-prone plaque, or that unstable plaque, is because it's more likely to rupture because the walls are so thin, and it's when we're still pushing out on that growth of the atherosclerotic plaque instead of invading the actual lumen of the blood vessel itself. So you're not feeling signs and symptoms of having heart disease, and you don't know you have it, but that wall is really thin, and all of a sudden something catches on it and it rips a little bit of it, and that atherosclerotic plaque is going to leave the intima and go into that artery and can clog it, activating the whole clotting system that we have with platelet activation, right? As we are building up worse and worse habits and the atherosclerosis is getting worse and worse, it's starting to build up that fibrous cap that lays it down, and it makes it less likely to actually rupture. So this is just going back to that, we don't know that we have heart disease often until it's just too late because we're so far advanced and just didn't even realize it. Okay, so what are some of the things that we can do to figure out if somebody's having a heart attack? We can take a look at their the enzymes, right? And taking a look at enzyme markers that we have. So they have elevated cardiac enzymes. Creatine kinase is a marker of a heart attack, in which it's a marker of injury in general, but you can look at it and it appears higher levels about 3 hours after a heart attack. It'll peak around 12 to 24 hours after a heart attack, and then it usually returns to baseline within about 48 to 72 hours. So they will conclusively talk about heart attacks when they start looking at these cardiac enzyme markers that we have in our bloodstream. Cardiac troponin 1 is another one. When we have damage to the muscle because of what's happening with the tissue death and it starts to break apart, we get that contractile protein is actually starting to be released in the bloodstream as well. It usually appears about 3 to 6 hours after a heart attack, peaks around 24 to 48 hours, and can remain elevated up to about 10 days. So you'll actually see larger amounts of that further away from the heart attack. As you know, and you've been working with Corey or will be into the future, we're taking a look at the ST segment elevation and looking at just what are the changes that we're seeing in our EKGs. We're going to let Corey handle the most of that. And I think most of it you've probably already gone through, and also taking a look at that pathological Q wave that they have that will show that there's actually been a heart attack in that area. And then inverted T waves that can last for a period of time, usually up to a year or so. You'll see that that inverted T wave, and you can actually see that in this little diagram right here. You have ST segment elevation that's going to start to happen. This is just moving from 0 hours. So this is like go time for the heart attack, and then working up its way as we move down the screen and taking a look at what happens with that T wave over time. So about 24 hours or so after the heart attack is when we often will get that inverted T wave, and that will last, at least for a good few months. And then usually by a year, when it comes back, you'll find that it has an upright T wave again, but in a slightly different shape. All right, so other ways that we can take a look and diagnose heart attacks in the hospital, we can actually take a look at an echocardiogram, so a sonogram or an ultrasound of the heart itself. It's looking for the detection of these wall motion abnormalities to try and look at, is there abnormalities, is it asymmetrical, right? And they can actually measure things like the ejection fraction to be able to know how much contractility we're having within the heart. And just kind of look for dead tissue in those regions as well. So Chris already talked about the different things that we can do, right? Ceasing the activity, giving aspirin, nitroglycerin in order to act as that potent vasodilator to be able to get that blood vessel receiving oxygen again on the other side of it. Oxygen administration, that's still like if their oxygen levels are low enough, because we don't want to be causing more vasoconstriction. Morphine, and then they're in the hospital, they can give like thrombolytic administration as well to help break up the clots in order to reperfuse things. So just looking again at our nitroglycerin, the way that it acts and the mechanism of injury when we're dealing with this in our heart patients is that it actually forms nitric oxide, right, in the system. So once we administer nitroglycerin, either through the spray, through a tablet, or through the patch, when it gets into the bloodstream, it actually converts into nitric oxide. And earlier, not in this lecture, but in the last lecture we looked at, one of those potent vasodilators that we had was actually nitric oxide to be able to dilate blood vessels. And so that's how that actually works. So it relieves the angina, both in the venous and arterial dilation that's going to happen, because we do have muscular walls within the veins as well. They're just not as prominent. And then also in the coronary arteries as well. That you'll see those. And so those are the different examples of ones that we have. I used this presentation for another class before who were not as familiar with it and haven't been doing it since they were basics. So common adverse reactions, make sure you're looking for the hypotension, dizziness, and syncope that could potentially come with them. All right, so now what I wanted to get to, the whole point of me doing this is to be able to talk about some invasive treatments that happen when somebody has had a heart attack in the past, right? So there are some invasive techniques that can happen, such as angioplasty, and that can be with or without a stent placement, and also coronary artery bypass grafting, what we also know as CABG. So taking a look at what we're looking at with angioplasty. So what they'll actually do is they'll go in, and usually it's coming through the femoral vein or sometimes the femoral artery, but usually the femoral vein, and they'll work their way backwards until they can get in to the heart vasculature itself. And they will take this little probe right here. So you can see this is our atherosclerotic plaque in A, in our little panel A that we have there. And you can see that it's impeding that diameter of the lumen itself, right? So we want to go in and actually work to be able to open up that blood vessel manually, like physically, to be able to do this. So they'll put a little probe in that'll go up through the femoral vein until it actually, and they'll use a little like scope to be able to see where it needs to go and when it actually hits those time periods or those places where there's a lot of atherosclerotic plaque that's built up. It has to be somewhat soft and pliable in order for you to actually be able to move it away. Then this probe has a balloon that's deflated on the end of it. You can see that in B. And then what they'll do is they'll actually inflate that balloon right here in picture C, and it'll take that plaque and squish it against the walls of the artery, right? That's what the angioplasty does. Now, they could just leave it at that, or sometimes what they'll do is actually follow that up with what's called a stent. And a stent is like a little mesh wire contraption that will get placed in this exact same area where that balloon was, and it'll just hold it in place. Sometimes those are medicated, sometimes those are not medicated. The benefits of medicating them is that it tends to have less of a chance of actually activating the clotting mechanisms around that, right? Because our bloodstream is like, this is a weird thing that's within our blood vessel. I don't like it. Sometimes it actually activates the platelets and will end up causing clots. And even though you just had your artery opened, now we've got an actual thrombus that is blocking the blood flow of what's happening, or just a calcification that's there. So the angioplasty will increase that artery perfusion by actually compressing, like manually compressing the plaque. Sometimes it'll go in and actually scrape the vessels as well, and then it follows it along with a little bit of like literally looks like a vacuum cleaner, in which they'll like scrape some of the plaque off and suck it right back up away so that it doesn't go out into the rest of the periphery. And it'll stretch the wall of that blood vessel in order to increase that diameter. So who is usually the people who are good candidates for this would be patients that have a softer, less stable plaque. If it's too hard, you can't push it and compress it, right? So it's got to be a little bit more compliant in order to that compression that we have. This is also used when it's typically like a single vessel that's being worked on instead of multiple vessels. If you've got like 4 different blood vessels that are all impacted, the risk becomes a little bit too great. And also if there's a lesser extent of the occlusion, and if they're in the larger portions of the coronary arteries. So as you get more towards like the distal ends of the coronary arterioles or arteries, they don't tend to work quite as well because you can't get the probe down there into the smaller blood vessels as easily. So that's kind of the candidates for people who are up for angioplasty. And so now that you understand, when your patients will come to you and say that they've had angioplasty or they have a stent or don't have a stent, you can understand what these words are. Then besides that, we also have what's called coronary artery bypass grafting, affectionately known as CABG, right? CABG involves actually surgically bypassing the vessels that are blocked by grafting a different blood vessel in place. So what they'll do is they'll go in to some of your veins, like the saphenous vein that's in the lower portion of your leg, like in your calf area. They'll take a section of the saphenous vein out. There's a lot of vasculature down there, so it doesn't really seem to impact the blood the blood flow returning from the legs very much. But they'll take a section of that out, or what's called the internal mammary artery, which actually runs down the very inside of your rib cage. It's kind of suctioned in there into the pleura that you can actually find those layers that you have within the chest wall cavity. And it actually usually takes an artery from there. They're both about the same in size, which are equivalent to what you see with the coronary arteries as well. So they'll actually take these arteries out and create bypass systems instead of having the natural bypasses, because they're obviously not working. We're going to go through and we're going to patch in these arteries to open up this bypass to be able to get from one section around that lesion and that blockage to the more distal region of it. So who is more a proponent or candidate for these would be older patients that have had a higher number of years that are impacted by cardiovascular disease, when there's multiple coronary artery occlusions that are happening on. So it's like in multiple different coronary arteries that there's blockages there. If the plaque is more stable and it has that fibrous cap and you can't actually compress it out because it's not compliant, or if there's individuals who are just having significant reductions in their cardiac function. So their ejection fraction is very small. They're not able to actually beat the heart as much as they can. So more of our advanced congestive heart failure patients and such. So those are kind of those pros and cons of like who gets what. So if somebody comes to you and they're like, I've had a CABG times 4, that means they've had 4, like it's a quadruple bypass. That's another terminology that they would use, right? And it means that they had 4 of their coronary arteries bypassed using the either saphenous vein or that internal mammary artery that we have. So as far as waiting, like, do you go cabbage? Do you do the percutaneous transdermal coronary or transluminal? Sorry, it was hiding and I can't speak today. The percutaneous transluminal coronary angioplasty. We often just call it angioplasty or stents, or we can call it PTCA, right? The pros and cons between them. Cabbage has a higher risk compared to angioplasty. There's also a greater cost that's associated with it compared to the angioplasty. It's more invasive compared to the angioplasty. It has a longer recovery, about 6 to 9 days in the hospital, versus if you do like angioplasty, sometimes it can even be outpatient, but usually it's about 1 day stay, maybe 2. However, you do get longer lasting benefits with the cabbage, right? So 93%, 10 years after the fact, those arteries are still patent and have good flow going through them. Versus you have shorter lasting benefits when you're getting angioplasty done, and sometimes it actually risks being blocked again, and actually the medication tries to help deal with that. So treated stents with the medication tries to decrease the risk of having that restenosis or that additional blockage that happens. If we are putting in healthy arteries and veins that came from other places in our body and putting them into our heart, there's a greater resistance against building up additional new atherosclerosis or those plaques that are built up, versus there's less resistance to it when we're dealing with angioplasty. So those are kind of the pros and cons between those two as we see them. So that is it for this video. Thank you for hanging in there with me, and I hope you guys have a good rest of your week.